We thank you for your interest over the past years in our regular programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves in offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass.
And we're live in 5,
4, 3, 2,
1.
We started? Yes.
Okay, great. Well, welcome everyone. Thank you for the Seattle Science Foundation for the kind invitation. It's a truly, personally for me, an honor to come back and be able to host now from St. Louis University, the virtual journal club. Now that I'm faculty here, I think we have some great articles. I have a couple of slides I'm going to share. I see Dr. Chapman. Hi, Dr. Chapman. How are you?
Hey, good morning. Thanks for doing this super hot topic. I just came back from the Global Spine Congress, and finally, the deformity world is coming around to the fact that it's not just angles and maybe bone density, but that thing called muscles and sarcomeres may have something to do with it. So highly timely. Thank you for doing this.
Of course, of course. Yes, I mean, it's one of the things that, we talk so much about hardware, right? And as I mentioned here, we went from freehand to navigation to robotics. So now we all know how to play screws, right? We're getting better understanding about the parameters, sagittal parameters, coronal, the cone of economy. But even despite all of that knowledge, there's still something missing, right? Some of these patients still don't do well, and there got to be something else. And just a couple examples, just from my own practice, right? I think visually we can see this here, right? We can see the muscles, visually, even if you don't measure anything, our eyes tend to go some places. And I'll tell you now that, a lot of us are doing laterals. Now we're looking at the psoas muscle, which usually in the spine world, before that, we even look at it. Then we see muscles like this, right? And even with zero measurements, just our eyes, pattern recognition, we see there's something different compared to, like, let's say these paraspinal muscles, right? These are two different females. Now this is a male, has adjacent stomach disease. We see the stenosis, but then we also look around outside the spine and then we see those muscles and we see there's something different, right? And even if we don't know it, most of us, again, just by the sheer volume of seeing MRIs, there's something different. Compared to this one, a 49-year-old who has spondylolisthesis, but his muscles are much different than this 74-year-old. So there's a lot of literature now on prehab, on things to do before surgery. Our ERAS protocols are getting better for spine surgery, diabetes, weight control, NPO guidelines. So as Dr. Chapman was saying, I think overall the spine field is getting more and more realizing that we need to do more than just bone angles, and there's something else that needs to happen. And of course, I couldn't, be here and not mention our Haagen-Dazs diet that Dr. Chapman pioneered over there in Swedish. And then of course, I have my own version here in St. Louis. I think my residents here will make fun of me because I'm probably the #1 prescriber of Ensure High Protein for our patients. They get 3 times a day. So I think we'll all come to realize that there's something else going on as well. We have 3 great presenters today. Jorge, he's our current chief resident in neurosurgery. He's already accepted a University of Miami Spine Fellowship that he'll start next year. Jason Horowitz, he's one of the chiefs in ortho, and he's starting his UC Irvine Spine Fellowship coming up soon. And Mayor Patel, he's one of our junior residents, and he's a future spine fellow. We're still trying to find him a fellowship. So for people who are in there, he's going to be a great candidate coming up soon. So I'm going to stop sharing. If Jorge, if you want to start.
Yes, let me share my screen. All right, good morning, everybody. Thank you for having me. As Dr. Avila said, I am Jorge Urquiaga. I'm PUI 6 neurosurgery resident, current chief resident here on this hot topic of Sarcopenia Journal Club. So from the get-go, I got to talk about this article published just actually a couple months ago in April in the Journal of Clinical Spine Surgery. The title of the article is "The Influence of Paraspinal Sarcopenia on Patient-Reported Outcomes Following Lumbar Fusion." This article is coming from the Department of Orthopedic Surgery at Northwestern. To begin with, sarcopenia, there are many definitions of it. What I got here, progressive loss of skeletal muscle strength and mass associated with systemic inflammation and decreased stress response capacity. Many surgical subspecialties have investigated the perioperative risk of sarcopenia for surgery in general and demonstrated an increase in patient cost, complications, worse outcomes. And despite this, traditional risk stratification metrics like the ASA, like the American Society of Anesthesiologists, and the Modified Frailty Index have not integrated sarcopenia into their preoperative assessments, which is something important to now probably consider. Some background about this topic in spine surgery. In the last few years, spine surgeons have started looking beyond bones and ligaments, and now are more frequently watching over the muscle surrounding the structure we operate on, which is the spine. And more importantly, recent evidence suggests that localized paraspinal sarcopenia is a distinct pathology from generalized sarcopenia, which suggests that not only general, but also spine-specific sarcopenia should be considered for spine patients. For now, spine surgery literature has tended to evaluate spine-specific sarcopenia through paraspinal muscle morphology using preoperative MRI. For us, from a practicing spine surgeon's perspective, this approach is practical and applicable because we can easily obtain and review, MRIs before surgery. Now, prior research has demonstrated that paraspinal sarcopenia has an impact in outcomes and alignment after spine surgery. However, most of these studies are a little bit incomplete or only evaluate a single muscle group or only measure the size as opposed to, for example, fatty infiltration. So that's kind of like the interesting thing coming up in the different research articles. So when it comes to understanding paraspinal sarcopenia, we're still sort of like figuring it out, and that's the importance of this article. At the time this article was in the making, no single study had assessed the influence of fatty infiltration or cross-sectional area for all paraspinal muscles on patient-reported outcomes measurements information system, PROMIS, which is a type of PROMS, a patient-reported outcome score. And in this article, what they consider all paraspinal muscles was the psoas major, multifidus, and erector spinae. The majority of the previous literature on lumbar paraspinal sarcopenia utilized traditional metrics of patient-reported improvement, for example, ODI that we use a lot, or SF36, but not PROMIS, this specific questionnaire, which is what the authors consider novel about their study. Here we can see what the PROMIS is. This is the questionnaire they used. The PROMIS has different domains. In this case, they used the domain for pain interference, which means basically how much pain interferes with their daily activities, and also physical function. It actually took me a while to find these questionnaire samples without hitting a paywall, which was kind of interesting. The objective of this study was to assess the impact of pre-op radiological markers of lumbar paraspinal sarcopenia, including fatty infiltration and cross-sectional area of the multifidus, psoas, and erector spinae, which again is what they consider all the paraspinal muscle groups, on this PROMIS questionnaire on the domains of physical function and pain interference in 1 year following lumbar spinal surgery. The methods of this article, it was a retrospective cohort study. Patients over 18 years of age who underwent primary lumbar fusion between 2012 and 2018 were identified at this single tertiary academic institution. The inclusion criteria were 1 to 3 levels of primary lumbar fusion, which could be interbody and or posterolateral fusions, identified all obviously through this retrospective chart review. All patients included in this study had a lumbar MRI within 1 year of surgery, and they assessed again for this PROMIS questionnaire on physical function and pain interference scores. And they were also evaluated again 12 months post-operatively. How they assess the image information about the paraspinal muscles and the fat infiltration? Well, they obtain a pre-op T1 and T2 weighted image on an axial MRI of the lumbar spine, all at L3, L4 disc space for the cross-sectional area of the multifidus psoas and the rectus spinae. All the muscles were measured by outlining the fascial borders, and you can see here on the screen, you see this yellow line around the muscles. That's how they delineated each muscle group, and they measure it. The cross-sectional area was calculated as the average of the left and the right side muscle. And then the percentage of fatty infiltration was also measured for these muscles, and you can see it in red. They had this software called ImageJ that has some sort of like filters, and that's how they were able to measure the fat infiltration, and they had two independent reviewers obtaining the information and reviewing this data. Statistics of this article were pretty sound. I'm not going to go too much into the detail, given that this was not a complex statistical analysis. Per usual, continuous variables were analyzed using t-test and Mann-Whitney for parametric, no parametric data, respectively. And categorical variables were analyzed using chi-square. P below 0.05 was the significance of level, but probably the most important measurement was this MCID, which is the minimum clinically important difference. This is an important term to know. Simply put, it's just the smallest change in a health outcome that a patient would consider meaningful or beneficial. In this particular article, this MCID was defined as an absolute change in PROMIS score in these questionnaires of 8 for both the physical function and the pain interference domains. So jumping into the results, here we see the table of the demographics and also the first variable analysis they made. A total of 87 patients met the inclusion criteria. As you can see here in the table, the mean age was 62.3 years old. The mean BMI was 29.6. 40.2 of the cohort were males. On the bivariable analysis on the right side, patients' demographics such as age, BMI, MFI5, sex, or ASA class were not significantly different between patients who met versus those who failed to meet this MCID, this clinically relevant, clinically important difference for the PROMIS questionnaire for physical function and pain impairment interference. Also, on the bivariable analysis on the right, patients who met the PROMIS pain interference minimum clinically important difference demonstrating significantly greater preoperative pain in the form of higher baseline PS score. Again, meaning, let me go back here. On the right, on the far right side, you can see that 0.005. That's the baseline PROMIS pain interference. So those who had a high score on that parameter, post-op were significantly, statistically significant for also meaningful clinical change in that part of the questionnaire. Now, also on the bivariable analysis, patients who met the PROMIS, the fatty infiltration of the erector of the psoas muscle fatty infiltration, they saw that there was statistically trend towards significant, this this term that is used. And because of that, they decided to run another multivariable analysis to see how this was actually affecting the statistics and if there were any confounding variables. So here we can see the next table, which is the multivariable analysis comparing paraspinal fatty infiltration and the demographics of on meeting physical function and pain interference. And you can see here that, again, the pain interference minimum clinical important difference was significantly statistically significant at the bottom right for baseline PROMIS pain interference. No confounding variables were found to be independently predictive of meeting the PROMIS physical function or on this specific parameter. But again, you can see that lesser psoas fatty infiltration was significantly associated with having PROMIS physical function minimum clinically important difference. So again, the two things that they found significant among all the things that they studied was a pre-op promise score in the pain interference domain. That having a low score there would mean that post-op would have a higher impact on this domain. And also the psoas fatty infiltration, having a low fatty infiltration would mean that they would have a higher physical function.
Hi, I'm Jens Chapman, and welcome to the Seattle Science Foundation.
Now, here we can see the two plot graphics that they depicting each of these statistically significant associations. Again, you can see on the left, the promise pain interference score at baseline was directly, proportionate to the impact of after surgery. And on the right side, you can see that inverse relationship, the fatty infiltration on the psoas muscle. If it was low infiltration, it would have a high physical function post-op, and then they will go, downhill as the psoas infiltration would increase. So what are the key takeaway points of this study? One, increased psoas fatty infiltration negatively impacts the likelihood of clinically meaningful improvement in physical function after lumbar fusion. Number two, fatty infiltration, particularly for the psoas, because it was not significant for the other muscle groups, may be a better prognostic marker than muscle size, the cross-sectional area, for outcomes after lumbar fusion. They discuss about the potential mechanisms for this. As we know, a very important part of the stabilization of the lumbar spine comes from the psoas muscle. So if you have fatty infiltration, that would mean an impaired, probably weakness of this muscle, impaired stabilization, which would lead to worse outcomes. Another important thing to think is that the preoperative assessment of the psoas fatty infiltration using the MRI that we all have available for pre-ops surgeries could be useful in discussing with patients the potential long-term functional improvement. What are the limitations of this study? Retrospective, always prone for selection bias. It was a small sample, 87 patients, which limits the statistical power. It was a single-center study. The thing that it was particularly interesting to see is that they would not differentiate between the fusion approaches, even though they have posterolateral and interbody. They did not specify if it was like lateral interbody, anterior interbody. They would actually also consider like both approaches at the same time. So they did not differentiate or stratify for this, which was, again, interesting to see.
Thank you, Jorge. I think this paper was very interesting because one is the way they measure it, right? I think there was a question. I mean, using their software, but is literally just outlining where they see fat, and that software basically calculates the amount of fatty infiltration, which again, I think visually we can all also see. As you mentioned, I think still 90 patients is a good size. I would have liked that this paper to talk about the specific approaches, right? I mean, I don't know how many they did transpsoas and minimal invasive versus, maximally invasive in a way. But I think overall, if you forget about it, they're showing that if you have more fatty infiltration in your psoas, you're more likely to get bad outcomes after surgery, despite the type of surgery.
Jorge, very nice paper, good selection. As I said in the beginning, hot button topic. So we are, in full disclosure, doing several projects around sarcopenia. And one thing that surprised me about this paper, and again, this is the value of journal clubs. We see articles that somehow I missed this one. They used a measurement of the psoas that I was not aware of before, and that's fatty infiltration of the psoas. We have used in one study fatty infiltration of the paraspinal muscles, specifically the multifidi. That's well known, and we have a correlation study with that now. And then the other study, the other system that I'm familiar with is at L3-4 at the disc space to measure the circumference of the two psoases, regardless of the fatty infiltration, add them, and this should be the same as the cross-section of L3-4 disc space or slightly bigger if the patient is not sarcopenic. So this fatty infiltration software, that's kind of cool to see. I was just not familiar with it. Is that validated, or how did they validate that actually?
I actually look into the methods, and they do not specify how actually they use the software or if it was validated or not. I'm not particularly familiar with the ImageJ. That's the name of the software that they use. They said that they had independent reviewers doing it, and they had some sort of the filters and functions of their software. Now, obviously, that would be interesting to see how you apply that to the general spine surgeon practice, right? Because then you would have to have a software that allows you to easily acquire this, delineation of the fatty, which again is very important. And then the other thing that you just mentioned, Dr. Chapman, is that this L3, L4 disc space, I also don't know if it's standardized to do it at that level. I think in some of the other articles that we're going to discuss today, they use L4, L5. So that will be interesting to see if there is some reason for that, or a way to have a uniform level to measure these kind of parameters.
I'm here. Dr. Abdul Jabbar is here. Do you want to comment on that? Because, I mean, we've discussed this many times in our research session.
Yeah, I think this is another good study, obviously very recent. I think we all can kind of see in our minds that our patients that are less fit and, more challenged in terms of mobilization don't do as well. And we're all looking for ways to kind of quantify that objectively. And, looking at the cross-sectional area of the psoas, looking at the fatty infiltration. It was interesting to see how the psoas is more predictive here than the paraspinal muscles. I think one interesting thing looking forward is if we see this in our patients and we think they may not be great candidates for a bigger deformity type surgery, is this something that's actually a modifiable risk factor? And I think that'll be an interesting thing moving forward.
I think that's the big question.
Yeah.
I truly think it is. I think Dr. Patel's paper talk about PJF and PJK, and back to the point about the fatty infiltration. Dr. Horowitz's paper, it's mostly published beforehand in the cervical spine fatty infiltration, and it's taken from the general ortho literature. You see, there's going to be a Goutelier classification of fatty infiltration, which I think it's in one of the upcoming papers. And I don't know if Dr. Patel is available. If not, we can go with Dr. Horowitz. Oh, you're there? Okay, great. Maybe.
Yes. Okay. My topic today is talking about sarcopenia in paraspinal muscles as a risk factor for PJK and PJF. This was published in a JNS Spine in 2024. This study took place in South Korea, and it was a single center retrospective study. So basically, as we talked, so adult spine deformity often leads to complications like PJK and PJF. In the study, we define PJK as an increase in kyphotic angle by greater than 10 degrees. PJK is usually benign. A lot of these patients don't require significant surgical management, and they're followed clinically. However, PJF is a structural failure. Either that can be like a vertebral fracture or hardware failure or something like that. That can have serious outcomes. And these patients who have PJF, proximal junctional failure, typically require surgical intervention for correction. The known risk factors for proximal junctional kyphosis or proximal junctional failure include older age, BMI, and then patients who are osteoporotic. The number of levels fused, so fusion, especially the sacrum, the higher number of levels that are fused, the higher risk for PJK and PJF. Some radiological signs that are indicative of or could suggest PJK or PJF are positive SVA, PIL mismatch, kyphosis greater than 4 degrees, junctional angle greater than 10 degrees. And here, the hot topic that we're discussing today is sarcopenia, so loss of muscle mass and function, especially in the paraspinal muscles that contribute to PJK and PJF, and which is what the authors of this study were trying to determined. So the aims of the study, they pretty much have three big aims. So one was assess the risk factors for PJK and PJF, including paraspinal muscle atrophy. The other one was whether the multifidus or the erector spinae muscle or the psoas muscle contributed to the development of PJK and PJF, and they looked at each of these individually. And then the third one is to compare paraspinal atrophy between PJK and PJF. So methods, like I mentioned, this is a retrospective analysis of 57 consecutive adult spinal deformity patients who had long fusions, and we'll kind of talk about the fusion levels as well a little bit later, who had greater than 2 years of follow-up. So in the PJK and PJF, there were about 25 patients, 13 PJK and 12 PJF. And then in control groups, there were 32 patients who didn't develop PJK or F. What they looked at is the muscle volume, very similar to the paper that Dr. Urquiaga presented. They looked at multifida, erector spinae, and psoas muscle at the L4, L5. The reason they picked L4, L5 was because there was a paper published in 2019 by Shia, who did a correlation study of all the different levels from L1 all the way to L5S1, and they correlated the disc, essentially the disc area or the cross-sectional area from there to spinal pelvic parameters. And the one that they found at the highest correlation was at the L4, L5. They looked at fat infiltration and radiological measurements, SBA, lumbar lordosis, PILL, and then pre and post-operative changes. Basically, a lot of this statistical analysis here is univariate, multivariate regression done in SPSS, and the way they specifically measured the muscle volume here was they did the ratio between the muscle and then the vertebral volume at L4, L5 of the three different muscles that we're discussing. And then muscle function was measured in terms of the degree of fat infiltration in the multifida and the erector spinae. So, here, the top figure here is kind of showing how they did the calculation for the muscle volume, and then the bottom figure, figure 2, is what they did, the Ayres point to muscle infiltration. This paper does not really go into specifically what software they used to calculate their muscle infiltration. All they said was if they graded it by MRI, so less than 10% fat signal would be a grade 1, 10 to 50% would be grade 2, and greater than 50% of fat signal in the muscle would be grade 3. So some overall results from the study. So PJF developed a lot earlier than PJK, typically 1.7 months versus 15 months. There was significantly greater pre and post-operative SVA in the research group. The PIL mismatch was not statistically significant in their study. Specifically, out of all the three muscle groups that they tested, the erector spinae vertebral disc ratio was significantly smaller in the PJK-PJF group compared to the multifida or the psoas. They did not find any statistical significance with the muscle volume loss with the psoas or the multifida relating to PJK and PJF. For fat infiltrations, they were higher, again, in the PJK and PJF group, but they were statistically insignificant. And the PJF patients generally had severe atrophy compared to the PJK patients. 9 out of 12 PJF patients did require revision surgery afterwards. Going into some of their results, so basically here in table 2, they mentioned their analysis shows that patients who had a higher SVA pre-op and a higher SVA post-op were more likely to develop PJK and PJF. In table 4, they basically mentioned that their pre-op and post-op SVA, as well as the erector spinae muscle volume, was statistically significant in developing PJK and PJF. So they mentioned that as some of the highest risk factors. And then when they were comparing the difference between PJK and PJF, so you can see that the rector spinae had more loss of muscle volume in the patients who developed PJF compared to the patients who developed PJK. So overall, like we mentioned, so erector spinal muscle atrophy essentially played a central role in junctional failure. They kind of mentioned the explanation that was provided in this paper was that the multifidi are more of a deep muscle that attach directly onto the spine and help with spinal stability, versus the erector spinae are more superficial and they're just deep to the thoracolumbar fascia. They consist of, three large muscles, cerebrum spinalis, longissimus, and iliocostalis. They're a lot more related to the spinal movements as opposed to just stability, and to help maintain a stable posture as well, especially with gluteal muscles. So that's why, this volume loss in erector spinae seemed logical where compared to volume loss in the multifidi psoas. The greater SVA correction may also overburden weakened junctions, especially considering the patient population that they had. A lot of their patients, the mean age was like 77 years old. Over undercorrection of sagittal parameters can contribute to both junctional issues, which supports the findings that poor thoracolumbar muscle quality can lead to PJK. The recommendations from their study was consider like gluteal and extensor strengthening pre and post-op. And I know, as Dr. Avila mentioned, the importance of adequate diet and adequate protein intake, especially for elective cases. So optimizing pre-op before surgery, and then surgical caution and overcorrecting SVA in sarcopenic patients is important. They also recommended that every elective patient who does have adult spinal deformity correction do get a preoperative MRI to look at the muscle volume that they have, and then again consider exercise and diet prior to surgery. Some of the limitations that this paper did have is similar to the prior paper that we discussed. It is single center, it is retrospective, low end was 57. And they did mention, that they were trying to look at long construct, but overall their mean number of levels that were instrumented was 4. I think 4 to 4.5. So in their limitation, they did mention that patients who do have long construct fusion greater than 4 or 5 levels may have higher risk of PJK, PJF, and would also, potentially have worse or greater volume loss and greater fat infiltration. Also, one thing that I did want to mention is, their average BMI in this study was about 22 to 23, and the mean patient age was about 76.4, which can limit generalizability. It depends on practice, depends on location. A lot of patients sometimes may have a higher BMI and they may be younger. Patients with higher BMI may have more fat infiltration. And may have a higher likelihood of PJK or PJF. And, in this case, patients were a lot older, which also may affect generalizability because these patients may also have a higher likelihood of PJK, PJF, and more muscle atrophy. Thank you.
Great paper. Dr. Avila, when was the last time that you had a spinal deformity patient with a BMI of 22?
It's been a little while. I think Jorge and I were talking about potentially publishing my series of above BMI of 50 trauma that we had here in the Midwest, that unfortunately they come with bad fractures and spinal cord injuries, and we have to operate. But yeah, I agree. As Mayor was saying, the generalizability is going to be hard, and I think also they have something like 70% were female as well, right? In this paper, so that will limit. And this and the other paper too, that I think they mentioned that truly we don't have like a baseline, like what should be baseline, not sarcopenia, sorry, but like muscle mass in the paraspinal muscles. We don't have that value, right? I think for bone density, we have DEXA, we have Hounsfield units, and we have some parameters. But I think so far it's hard for us to have that baseline parameter to compare to as well.
I just want to point out one thing. So Dr. Patel enjoyed that paper a lot. And again, it is very clear that we've missed something in spinal realignment surgery assessments in terms of successes beyond bone density and alignment achievements. And so that's really an important point that underscores that. Let me just quickly reminisce about Jean Debussy, who is kind of, I think, our godfather of modern deformity surgery, the three-dimensionality of scoliosis, the realignment, etc., the cone of economy. Those are all terms that he coined and underscored with great vision. A less known thing that really fits into this was his concept of the muscle jacket. And Dr. Patel, your paper again underscored that. He always talked about the muscle jacket. We should look for the muscle jacket in the patients and try to reactivate that. So maybe we can all combine together and reintroduce that term muscle jacket. Dr. Debussy just died 1 month ago at age 89. He was a frequent visitor here at the Seattle Science Foundation, and I'm proud to consider him one of my esteemed mentors. But the muscle jacket was one of his other terms. Just wanted to add that.
100%. I think we've been talking about this since the beginning of the session. We need to bring this back, front and center of like, okay, we figure out the screws, we figure out the angles. What else do we need to figure out to have even better patient outcomes after our surgeries? Okay, and then Dr. Horowitz will talk about, we're going to switch now to the cervical spine. And he's going to talk about laminoplasty, which is, I think, another procedure that in the last few years, at least in the US, has been seeing an uptrend. And you'll see here in this paper as well, the way they measure fatty infiltration and sarcopenia as well. Dr. Horowitz.
Good morning, everybody. Thank you for having me. I'm Jason Horowitz. I'm one of the orthopedic surgery residents at St. Louis University. Today, you're going to be talking about paraspinal sarcopenia and cervical laminoplasty. Paper I'm presenting is out of Spine. It's titled Paraspinal Sarcopenia is Associated with Worse Patient-Reported Outcomes Following Laminoplasty for Degenerative Cervical Myelopathy. It's a paper out of the Mayo Clinic in Rochester, Minnesota. Just first kind of start out generally about sarcopenia. It's progressive loss of skeletal muscle mass. More recently, we're identifying it as an independent marker of musculoskeletal frailty. And the interesting part of that is it's not included in most of the risk stratification and comorbidity indices that we normally use when we're looking at outcomes. Sarcopenia in general in surgery has demonstrated increased risk of postoperative morbidity and mortality across surgical specialties. Specifically in spine surgery, as in some of the papers we discussed today, sarcopenia and thoracolumbar fusion has had increased rates of proximal junctional failure, poor patient-reported outcomes. Sarcopenia and cervical fusion has had postoperative worsening of sagittal alignment. And the theory, at least one theory, being that the incompetent paraspinal musculature is unable to resist the lever arm of our fusion constructs. So this paper kind of asked the question, will sarcopenia have a similar relationship to postoperative outcomes in a motion-preserving procedure? And the vehicle they use for that is cervical laminoplasty. So the methods, there was a retrospective chart review of laminoplasties from C4 to C6 for degenerative cervical myelopathy. It could include a complete C3 laminectomy and C2 and C6 dome laminotomies, as well as foraminotomies at any level. They included patients were then stratified into 3 groups based on the Goudellier classification of paraspinal musculature, which was assessed on the preoperative T2 weighted axial MRI cuts, specifically at the C5, C6 level. The Goudellier classification. So for me, my first exposure to this was all rotator cuff pathology. We always use it to determine if a rotator cuff's repairable, if the muscle is still viable enough to repair the cuff tendons. The classification, grade 0 is this A box over here. That's no fatty infiltration whatsoever. Grade 1 is just minor streaking. Grade 2, you've got fatty infiltration, but there's still more muscle than fat. Grade 3, you have equal amounts of muscle and fat. And then grade 4, you now have more fat than muscle. For their outcome measures, they looked at the Neck Disability Index, the Visual Analog Scale neck score, and the Visual Analog Scale arm score. They also looked at their cervical sagittal alignment using the C2 to C7 sagittal vertical axis and measuring the C2, C7 lordosis. For the results, so in total, they found 114 patients that fit all of their inclusion and exclusion criteria. They were broken up into 3 cohorts. The mild sarcopenia cohort was Goudellier classification 0 to 1. That had 35 patients. The moderate sarcopenia cohort had a Goudellier classification of 1.5 to 2, with 49 patients in that cohort. And then the severe sarcopenia cohort had a Goudellier classification of 2.5 to 4, and there were 30 patients stratified into that cohort. As far as the neck disability index, preoperatively, they saw no significant differences in the mean NDI. Postoperatively, though, they saw significantly lowered neck disability index in the mild and moderate sarcopenia cohorts compared to the severe cohort. And patients in the mild sarcopenia cohort specifically were 2 times more likely to achieve the minimal clinically important difference and 6 times more likely to achieve substantial clinical benefit. As far as the visual analog scale neck scores, preoperatively, also there was no difference. Postoperatively, all cohorts achieved a significant improvement in the VAS neck scores. The greatest magnitude of improvement, though, was in the mild sarcopenia cohort. In the visual analog scale arm scores, preoperatively, again, there was no difference. Postoperatively, the mild and moderate sarcopenia cohorts demonstrated significant improvement. The severe cohort did not. And 10 patients in the severe cohort actually reported worsening of their VAS arm score versus only 2 in the mild cohort and 3 in the moderate cohort. As far as their cervical sagittal alignment, patients with moderate to severe sarcopenia demonstrated a significant increase in C2 to C7 sagittal cervical alignment at both 3 months and 1 year postoperatively. And patients with moderate severe sarcopenia also demonstrated a significant decrease in cervical lordosis at 3 months postoperatively. The conclusions the paper drew were that patients with severe cervical sarcopenia are less likely to demonstrate postoperative improvement in neck and arm pain and disability from laminoplasty. And in addition, patients with severe sarcopenia are more likely to report worsening of their patient-reported outcomes and experiencing worsening of their sagittal cervical alignment postoperatively, and they should be counseled accordingly. I think the tough part of this is these patients have degenerative cervical myelopathy, which, as we all know, the natural history of that is it's going to get worse. And these patients really do need decompression. We talked about today how both fusion and laminoplasty and these people with severe sarcopenia, they have a much higher chance of having worse patient-reported outcomes and worse alignment afterward. And so the question is, what do we really do with that information? It's not like a total hip where we can go, you know what, you have some risk factors, we're just not going to do this. You kind of still have to do it. So I think at this point, until we have a better operative option or a better intervention of some sort, all we can really do is counsel the patients that, hey, you're at much higher risk of having issues afterward.
Great job. Dr. Horwitz, can you go back to the slide with the alignment? Was there a correlation that I somehow missed that? A correlation of malalignment and sarcopenia. Where was that box? Did you see that, Amir?
Yeah, so post-operatively there was.
Yeah, so can you go to that box again? Somehow, what was it in degrees? So they had it categorically, not numerically listed. So here, oh yeah, lordosis, 10 degrees, 15 degrees. Because that's obviously the big deal. The single biggest worry that we have in laminoplasties, which is a fantastic and undervalued procedure, is postoperative kyphosis. And when and where does that happen? And I'm just trying to find.
So
oh yeah, here, okay.
The -5 versus minus 0.2.
Got it.
So the moderate to severe saw a significant loss of lordosis. I think it's interesting they had better lordosis ahead of time here, which you would think would be protective in our laminoplasty patients, but it actually wasn't. I think that's a very, very astute point that you're looking at.
So about 5 degrees, yeah, but that's something I can't explain. Dr. Avila, do you have any explanation for why a more sarcopenic group would have higher lordosis? Does that make sense to you?
It doesn't, unless they're trying to hyperlordose to try to, no, it won't make no sense to try to open, any foraminal spaces or anything. So I have no good idea what pre-op, they'll have a better lordosis.
But I think this does capture what we see in our patients who are not able to reactivate their muscles and keep a good lordosis. They don't do as well with a laminoplasty. And Dr. Horitz, you did mention, what do we offer these patients? And I think this just shows, with time, loss of muscle kind of quality. Maybe it's better to be doing a fusion in these patients. And I think we all kind of know that without looking at it objectively, but we do see there's some patients we just know are probably not good candidates for a laminoplasty. I think that this captures that very well in this paper.
So I want to just point out, thanks for going back to that data table, because when I looked at that in brief glance whilst you're discussing it, I thought, this is not that significant. Look at the 1 year postoperative box, mild versus moderately severe. It's basically, there's no real change there. There's no statistically significant difference. So I'm not sure I agree with that analysis that sarcopenia induces more malalignment. See, it's 8 in that 1 year post-op. The p-values are not significant, and that's 8.6 degrees versus 11.6 degrees summative lordosis. So
I think the one that was significant was the SVA. I think that's maybe box 5 or 6. Like a 1 year post-op, mild and moderate. I think that's, if I remember that, and the one in pre-op, there were the two that were significant.
Yeah, it's definitely a fascinating aspect, and I thought there was a very intelligent question, and there are, again, so many variables to consider in there. Again, I've not known of this paper beforehand. I feel silly, but thank you for unearthing that and discussing that.
Of course, and I think this is interesting because, again, a lot of us are trying to do more and more laminoplasties, and truly, I mean, I tell patients, right, theoretically, because we're not disrupting as much, you should have in theory, like a better pain outcome. But now we've add that sarcopenia part, as Dr. Abdul-Jabbar was saying. Maybe we should consider doing fusion in some of these patients, because I can only imagine if you have worse alignment, if you were already severe sarcopenic, and now you're kyphotic after laminoplasty, a revision surgery there is going to be even worse in terms of pain and recovery. So definitely something to consider. And back to Dr. Horowitz's point, right? Maybe we should start seeing the mild myelopathy with sarcopenia and then intervening earlier versus waiting until they're like a moderate to severe, on the MGOA scale, myelopathy before intervening. Maybe sarcopenia will become one of those additional variables to consider for an earlier intervention in maybe mild myelopathy if they're sarcopenic. Just ideas.
By the way, a good friend and much appreciated colleague, Dr. Richard Chua, again said to consider tubular surgeries to preserve the muscle jacket. And I don't know how to do it with laminoplasty, but of course that's a very big point, to reduce the amount of direct muscle trauma. Even when we do a, quote, open procedure, there are ways to not crush the muscles and destroy them totally. Wanted to just share one of our researchers here, Luke. He actually measured the psoas prospectively on a number of XLIFs of far lateral tubular surgeries, and he found something pretty remarkable. He found that the psoas, after successful surgery, actually increased in size. It went through a nearsighted damage of about 8% loss of muscle mass, but then even contralaterally, so on the non-approach side, the patients about a year out gained muscle function when they were reactivated, hopefully as a result of less pain and more functionality. So muscles are dynamic, they can recover, they can respond to stimuli. I thought that was interesting. That's not in print yet.
I mean, for sure. And again, I think this goes back to now, especially if there's elective surgery, we're talking about the prehab. right? How much therapy, or if we know we're going to do surgery, maybe do a different type of therapy to just try to, if not keep the muscles, try to increase the muscles, pair with nutrition. We're also working on some projects on nutrition on our end as well, because I think we all realize that there's more than just our surgery to do this recovery after.
Great. Do you have more papers to show, or do you want to?
No, those were the three ones I wanted to have enough time to discuss, because I know, as you said, this is a hot topic, and I know there are opinions about it.
Can we easily switch to Dr. Patel's paper, because I thought there was a really cool comparison. My question to summarize this would be for all, if it's not too much hassle, Dr. Patel, you had a great comparison slide of the different muscle groups to measure, like the psoas, the paraspinal muscles. It was a very graphic picture. What should we use as a screening tool in the here and now without buying additional software from some clever software company? I know it's a little search thing, but you know your talk very well, better than anybody. Yeah, I thought that was...
One of the things that I think is what was used even with Dr. Kiaka's paper was, what did they use for use? Is it ImageJ? So that's a free software that I've used before. It's very easy to use. Essentially what you do is you can just outline and highlight the area of what you're trying to assess, and that software will give you a it'll give you a measurement of the area as well, and then if you do it in 3D, it can give you volume as well. So it's very simple and easy to use. It's free software that I think anyone can use. I've used it before. I think it's very user-friendly.
So as we look at these different muscle groups, Amir, what do you think is the most meaningful? I've started using the psoas at L3-4 personally. I'll just out my bias, but I'm happy to learn or be re-educated. What do you look, or what would make most sense to you?
Well, I think that's the reason this topic is so interesting is because we've had a number of different studies that have said different things are most clinically important. And I don't think we're totally there in terms of knowing exactly, is it the quality of the muscle, which muscle, is it the size? I think we're clearly in the midst of figuring that out. I don't know that we're quite there yet, but just in terms of looking at the MRI, the fatty infiltration is something that I definitely look for, whether it's the paraspinals or the multifidus. The psoas is also clearly visible. So just in terms of clinic, I think, one, looking at the patient, obviously you can tell your patients that are very debilitated, but sometimes the MRI will surprise you, and really seeing a very small psoas can clue you into a patient that maybe need a little bit more optimization.
Let me ask the SLU Brain Trust here. A very cool topic, as I said several times. So how does sarcopenia tie into frailty? Frailty is the other big emerging dimension now. Is there a statistical input? Is there a odds ratio representation of sarcopenia and frailty? Can one of you or all of you kind of address that?
I'll tell you. The thing that we have about frailty is not tied, as far as I know, necessarily to sarcopenia and the paraspinal muscles. There's a lot of literature on frailty and sarcopenia, grip strength on elderly patients, and the walking test that they do. So there's a lot of literature on that, and those patients are frail. You have lower grip strength. There's a lot of literature on that. I think as of now, we don't have anything on the paraspinal muscles, but I think we're going to get there. To me, there's no question. Sarcopenia ties into frailty. So I think that's why this is such an important topic as we're talking about. But to specifically answer your question, I don't think there's a paraspinal muscle equals frailty, but there is sarcopenia, general sarcopenia, hand grip, walking test, and frailty. That is, I don't know the number, but there's a correlation there already on the literature.
I'll reveal another unpublished study of ours. When we looked at failures versus non-failures of adult deformity surgeries, I forgot what our cohort is, 80, 90 patients, something like that. We did a matched cohort analysis of failures and non-failures. Bone density was a factor, malalignment was not a factor, but by far the highest risk factor for failure, just like what was shown in Dr. Patel's paper and Jorge's paper, also Dr. Urquiaga. Muscle loss, sarcopenia, was by far the highest risk factor, right? I mean, it's substantially higher. So this is really a hot button topic. And obviously some of these things tie together, like poor bone density and sarcopenia are somewhat correlated. Do we have, and I don't know who of the three authors, presenters today can address that. Do we have a tie-in of BMI and sarcopenia? Sorry, not BMI, bone density, DEXA scores or Hounsfield units and sarcopenia? Is there a correlation? If we do a cluster cloud, are they overlapped? Because I think they are.
I'm trying to look into my article. I don't see I mean, at least when they measure for it on the bivariable and the multivariable analysis, they did not find a correlation, at least for BMI and the outcomes. Now, yeah, I think it would be interesting to see if BMI and osteopenia do have a relationship, because as we probably see more often than not here in our great Midwest population, a lot of the patients that come with extremely elevated BMIs, we do notice utilizing hospital units just in our own on CT scan, we can see that a lot of them do have significant osteopenia.
So take-home messages are we should definitely on all fronts investigate and look at muscles, muscle quality, muscle mass in the available spine imaging. And that's a really big deal. In your facility, are you using Hounsfield units now for routine assessment of spine bone density? Has that become kind of a standard?
Basically, I think our biggest discussion is if the cutoff, but we're all measuring Hounsfield units. And it's back to a point of how to measure things. It's super easy to measure, and I think hopefully we'll get that with the paraspinal muscles as well. But it's become basically routine for us to measure Hounsfield units.
And I'll paraphrase Dr. Randy Davis, a great colleague of ours. He has a two-folded question. I'll paraphrase it if I may. Is there any sign that muscle mass can be grown? I just made a statement about a pending SOAS paper that we're intending to publish in the near future. But is there any sign that countermeasures nutritionally, et cetera, surgically technique oriented, that they actually make a difference, a positive difference in muscle growth on patients? Do we have anything in that?
Not that I'm aware, and I think the bigger paper that we could, at least the three papers we had today, was the one that they pull all the lumbar fusions together, but they didn't break it down via MIS or non-MIS type fusions. But I'll be surprised if there's not something out there looking at just MIS, and especially now, of course, with endoscopic procedures, if there's probably something out there.
Great.
And I think that that lateral paper that we we're looking at, thinking that trans-psoas approach will likely give you some reduction in your psoas mass, was not true as we expected, and that actually the reactivation of being in less pain, being more functional, can increase the muscle size, something that we were not expecting to find. And that shows that, yes, this can change dynamically, and sometimes the surgery can improve it when you think it might counteract someone's mobility and their ability to develop strength. So I think that's obviously something on the frontier, and a lot more to learn here in this field.
Great. We're at time. We thank St. Louis University, Dr. Avila, and your wonderful team. That was a really cool topic and interesting cases and points. And I learned a lot from it because these articles were actually new to me. So this is, again, the benefit of a journal club. And we appreciate your insights and effort in doing this. Thank you.
Thank you so much for the invitation.
Thank you.